Well, good afternoon, everybody. It's our last, but certainly not least session beyond the pandemic with our distinguished panel up here. I'm Bob Baracco, who was introduced earlier as one of the folks that helped create this wonderful, wonderful event. And we've gone from the absolutely theoretical and going through the more emotional and the story part of it in the mid-morning. And then we ended up just now talking about the political implications and public health implications of vaccine hesitancy. And now we're going to close with a session that revolves around healthcare providers. And we talked a little bit about that throughout the day, about the mistrust that has certainly besieged healthcare providers and what we can do about that. Now we're going to hear a little bit about what happens beyond the pandemic, to what providers can do, and also their provider wellness to try and help prevent burnout or help treat burnout for the folks where it already happened. And I think, again, we're all well aware of some of the effects of the pandemic and its contribution to our healthcare staffing crisis that we're seeing across the nation now. And so with that, I'm going to introduce the speakers in the order that they'll be speaking. First, we have Dr. Timothy Friel, who served as the Leonard Parker Poole Endowed Chair of the Department of Medicine, Lehigh Valley Health Network since 2015 and still is such. He joined the Lehigh Valley Health Network in 1999, an infectious disease specialist with a special interest in HIV medicine. A graduate of Harvard College and Harvard Medical School, Dr. Friel completed his internship and residency in internal medicine at Mass General Hospital in Boston and finished his infectious disease and HIV/AIDS clinical fellowship in 1999 at the Harvard Combined Infectious Disease Program, Massachusetts General Hospital, and Brigham and Women's Hospital. Next, we have Kevin Carrell, a board-certified crisis response chaplain, and who's the manager of the Department of Pastoral Care, Lehigh Valley Health Network. He oversees pastoral care services for 7 of the network's hospital campuses. He has been working as a crisis chaplain since 2015. After undergraduate studies in management and marketing, he went on to take a master's degree in Christian history and a divinity degree. He also received a master's degree in pastoral counseling, and he is currently working on a doctorate degree in community care and counseling. Then we have Dr. Tessy Thomas, a pediatric intensive care physician and a bioethics researcher in the Geisinger system. Her primary research focus is on moral distress and professional integrity within complex socio-technical systems. As a clinician, she's interested in identifying, understanding, and further exploring the underpinnings of moral distress within multidisciplinary and interprofessional medical teams. Next, Dr. Kris Rooney has been a pediatric hospitalist with Lehigh Valley Health Network since 2008. She is also currently the system's chief wellness officer, vice chair of education in the Department of Pediatrics, program director of the Pediatric residency program. She holds a Doctor of Medicine from Penn State University School of Medicine and completed postgraduate work at Penn State Children's Hospital. And last but not least, Dr. Charlotte Collins is a clinical psychologist at Geisinger. She graduated with a Ph.D. in psychology from the University of Kansas and completed an internship at the University of Illinois at Chicago and fellowship at Harborview Medical Center in Seattle. Dr. Collins has worked at Geisinger for 15 years. Her current position is the division chief for the Center for Professionalism and Wellbeing. In this role, she creates and manages programs designed to improve the well-being of employees, enhance professional development of clinicians, and enrich a culture of respect and collaboration across the system. That's our panel for the afternoon. And with that, I will allow Dr. Friel to come up and begin his presentation.
Thanks, Bob. It's a great pleasure to be here today. And I thank the team for inviting me and my colleagues here to talk about it's really an important issue to all of us in healthcare right now. So I'm going to get started. There we go. So I thought just quick background, just tell a little bit about me. I call it BC, before COVID. And as Bob said, I am an internist and infectious disease doctor, and I grew up in the Lehigh Valley, and I returned there after the completion of my treatment to kind of work, practice, and give back to the community where I grew up. And did many I continue to practice to this day. I do mostly outpatient HIV work, but work very closely with the rest of my infectious disease colleagues. I became the chair for the Department of Medicine at Lehigh Valley Health Network and have had the great opportunity to help oversee my colleagues in the realm of primary care and medical specialties for the last several years. So that's kind of where I was up until February 2020. And ironically, the first case that we had of COVID-19 in Lehigh Valley Health Network happened to be one of my colleagues who were in the office, the same office that I do at LVHN. So right from the forefront, I was thrown right into the midst of this. Some have said, I was in the right place at the right time, given my background and my skill set as a leader and an infectious disease doctor. Others, and myself included, sometimes say wrong place, wrong time. But nonetheless, that's where I was March 2020 hit. And at that time, I was asked to take over and provide clinical oversight for our COVID response across the network and throughout our physician group. So certainly, I think it reflects, I look back on this, the most important time in my career, this time in my career, and I'm sure at one point I will get to the point, I'm not sure beyond the pandemic, I know that's our title, but I will say that this has been the most rewarding time in my career as well. So since the pandemic started, I have probably given over 250 to 300 lectures related to COVID. Most of my lectures and presentations include images like this. It's a really, really pretty image, and it can mean lots of things to lots of different people. But so you see this, it looks like waves. And, from my perspective, it does represent waves, and it can represent many different things. And it's in many forms. This could represent the number of cases we've had at Lehigh Valley Health Network, the number of deaths that we've had at Lehigh Valley Health Network, the number of tests that we perform, the number of healthcare workers that are out at any one time, or the level of stress that I and my colleagues are feeling at any point in time. We have lots of graphs demonstrating the different waves that we've experienced since the start. Certainly this night census, we peaked in January of 2022 with 580 people in beds at night. That day we saw over 878 people with COVID-19 came to our system in one form or another. So certainly one of the more challenging periods of time. But it certainly, if you look at this, it also, I think, represents what I would call the healthcare's emotional roller coaster that we've been on since the start of this. And I was asked before this, bringing this group together to really set context, what it's been like. So this is my perspective as both a physician who's been practicing throughout the pandemic, as a leader who's worked very, very closely with my teammates and team members who've been on the front line taking care of patients with COVID-19. And also, my life as a person, a dad, a husband, and a spouse. And it really has been a roller coaster for us. I'll talk about it in context of waves, and you can certainly see, I'll talk about the different periods of time. But this is how it started. We call it the first wave, and we certainly had a huge range of emotions and passions that we were feeling. Dread, fear, uncertainty, courage. There was adrenaline. There was so much adrenaline. We were all, but we had this overwhelming sense of purpose, I think, as we were all kind of brought together. Most of us, if we talk about what you go into healthcare, you want to help people. Well, this was our time. This was our time to be in the spotlight. Represent. There was a pace unlike we had ever felt before. And for one singular time, I think in our careers, everyone focused on one special, very, very important thing. But at the same time, we were also feeling that sense of isolation and grief and, unprecedented situations, because for us as healthcare workers, not only we were worried about our communities, we were worried about ourselves because we were facing a new pathogen that we didn't know much about. We didn't know how to treat it. We didn't know how to prevent it. And we ourselves ran the risk. And we were seeing videos and images coming from Italy and China of healthcare workers themselves dying as they were taking care of folks with COVID-19. So this was huge for us. We were also dealing with other things we had never experienced typically in American medical care. System shortages, worries that we wouldn't have enough ventilators, days when we didn't have enough medications, paralytic. Never expected stuff I saw when I did spend time working in Africa, but never in the United States. We were getting bombarded with overwhelming amount of information coming up to us from right, left, sideways, behind, above, and beyond. And this was all happening at this really crazy period where it seemed like everything across the world shutting down. We'd never experienced anything like it. This wave of extreme emotions in many, many different directions was something, profoundly unprecedented for all of us. And we all were forced to highlight some of the things that I felt my work as a clinician, wanting to provide empathetic and exceptional care at the same time, and being present, especially in a situation where we weren't letting family members come and stand by the side of patients. So we had to take on that extra role. We were managing personal fears, we were educating, we were answering questions all day long. From 5 a.m. often to 2 a.m. The days were long. As a leader, we were trying to remain calm and calm others. We were trying to be rational. Again, we were trying to prepare. We were trying to anticipate anything that could go wrong. And, maybe 50% of the time we got it right. And the other, every day we were faced with new challenges and emotions. We wanted to protect colleagues, our systems, et cetera. We wanted to innovate and educate. And as a person, we were doing all of this when trying to do our regular jobs as dads, moms, parents, spouses, all of that other stuff, balancing the fear and uncertainty that everyone else is experiencing, but also managing all the questions that were from our families, our neighbors, our system, everyone we worked with. So it was really, really tough. And balancing all of that and fun stuff, transportation, childcare, what's going to happen, and answering that persistent question, when's this going to end? And in the beginning, I think we said, this is a marathon, we're going to get through it. But the marathon continued. We moved to wave 2 and wave 3. Unique set of fears. The adrenaline started to go away as we started to feel new and different emotions. But we had new challenges that we were facing. Healthcare was now in crisis because we recognized this ain't going away. But we were also dealing with new challenges and fears, economic challenges, and this whole notion that people who had very real medical problems were staying away from the healthcare system, presenting with more advanced disease and more serious disease, all as we were dealing with even more patients as we moved into our first winter, who were succumbing to complications and actually dying in our system. We're also facing ongoing supply chain issues. The world seemed like it was in chaos. And there was a growing sense of not only that information, but misinformation. And in some cases, the amplification of disinformation intentionally devoted to divide us and perhaps thwart some of our efforts. Hope was on the horizon as vaccines came out, but that even itself led to lots of stresses for us. In the beginning, it was stress from our communities and our other healthcare workers. Why can't I get my vaccine? Well, we only have 100 doses today. Why can't I be the one? And how dare you judge and say that I'm not as important as the person that you picked? And we were hearing the same thing from our community. Flash forward 2-3 months later, we went from an excess, from not enough supply to an excess supply. As other people, we got through those who wanted, and then we had to start wrestling with those who didn't want. And we started to talk about things like mandates. And that's when we started to see a shift. And we talked a little bit about that before. So this was our challenge as we move forward, as we went to the fourth wave, the wave none of us expected when the vaccine effort came, and we hit 70% of our team vaccinated. We're celebrating the joys and beauties of taking off our mask for the first time in summer 21. None of us anticipated that the holidays would be as bad, not even as bad, worse than they had been the year before. So we were dealing with new problems. Vaccines were in the crosshairs. We were getting yelled at by colleagues who didn't want to get vaccinated. We had medications, which were great, but we didn't have enough of them. We're dealing with issues related to equity and access. There was a great masking debate that we were brought into in all forums, schools, universities, work, everything. And there was growing distrust in institutions that we were dealing with each and every day. We were dealing with higher volumes than we had ever seen in our healthcare system at a time where we had fewer employees. A, they were getting sick, so we were starting to see illness. And B, they were disappearing. They were leaving healthcare because of the traumas and other stresses that they had felt through the months and weeks before. And the world was still in a sense of chaos as we move forward. And then we move now to where we are. It's what I'll call right now the prolonged swell. This isn't going away. And that whole question of when does this end, I still don't has been fully answered. But we're continuing to deal with the issues. We're in a new phase. Great stuff has happened. Medications, hope, growing community immunity. We're transitioning to a sense of what's your personal risk versus what's the community's risk right now. but we are still dealing with some issues, still vulnerable individuals who can still succumb to complications. There's still that growing sense of emptiness and loss from what we've been through and are continuing to go through. We have scars that haven't healed, and there's still that uncertainty of what's going to happen next. What will the next fall, winter, and the months beyond look? And that, I think, has left us. We've gone through so many ups, and there were ups in the beginning because we really had that wonderful sense of purpose. Healthcare workers were elevated to a position on a platform where they were considered heroes. And there were parades, people coming by and clanking, pots and pans, driving by and honking, going through our healthcare systems, honoring us as heroes. And that was great, and it was invigorating, and it helped us get through it. But there was also a sense that, too, are we really heroes? Because we're still dealing with a lot of heavy stuff, and we don't feel like we're always successful. And over time, that started to change, and the parades went away, and the laudatory praises of heroes started to vanish. And we're starting to be overcome with the doubts and the information and the distrust in the medical field. As people questioned our reliance and our pushing for vaccines, and are we really looking out to the community with their best interests? And what are we doing? And are we misguiding our school boards by things that we are recommending as we're balancing all that other stuff? So what a huge sway, shift of emotions from huge peaks to really, really deep valleys that we've experienced. So I think, as I transition to my colleagues, I think we have to remember that there has been a toll. And, on a worldwide basis, we're talking about a pandemic that continues. We have already experienced 6.5 million deaths, over 600 million cases that we know about, and over 12 billion vaccines, the largest vaccine effort that we've ever had in the history of modern medicine. In the United States alone, over 1 million deaths, over 94.5 million cases, and we've distributed over 610 million vaccines. And if we hadn't been in that situation or had these vaccines, what kind of numbers would we be talking about? But as we reflect on that, this has just become our daily job, and it has faded into, it's become the new norm. And I think, unlike other things, and I think the thing that's really we all still continue to struggle with, this has been a war that we have been fighting, and there will be no ticker tape day because there's no official day when this will end. This has been a mass casualty event playing out over the course of 2.5 years, and there is no day after where we can process and bring in grief counselors to help us deal with things. So we are in this very, very weird situation and circumstance for the first time. And that's, I think, the context and the framework that we're going to continue the rest of our discussion. So I'm going to turn things over to my colleague. Thanks.
Hi, good afternoon. My name is Correll. I'm the manager of the Pastoral Care Department for Lehigh Health Network. Our particular office is based at the Cedar Crest and Muhlenberg campus, but we do cover 7 of the campuses. And what I'm going to try to encompass in the next minutes is to give you some sort of idea of what it was like to actually work alongside the healthcare providers, work alongside patients who, as Dr. Friel said, didn't have their family with them. They weren't allowed to come in and work with families over the phone or over an iPad. People that were dying, we would kind of sit next to them and work with the family members. It was something totally different than what we were used to, and certainly my career as a clergy member, extremely challenging. And we've worked 16, 18 hours straight each every day for a 2-year plus period. And it's just, it was a constant draining on ourselves. And as Dr. Friel alluded, we have family members, children, so it was extremely challenging. And our first priority was towards the staff members and patients and their families that we serve. So the idea what a chaplain is at a hospital, it's kind of unique identifier that's used, and we're actually ministers, clergy personnel that are trained just like your pastors are trained at the church. In addition to that training, we have an internship that we go through, as well as a year residency program. And then after that program, we get what's called board certified, where you have to go in front of a panel of about 4 to 6 people, where they kind of just treat you with questions and scenarios, to get certified. That's it. I guess you know what you're talking about. And we provide a lot of emotional and spiritual support. We do on the spot stress management. We do that a lot with employees. We did that a lot during the COVID pandemic. And one of the things I'll tell you that we're not the church police. One of the most questions that we get, or I guess statements that we get, is that when we tell them who we are, the first thing people will say, I haven't been to church in a year, or I haven't been to church in 6 years or whatever. So we're not the church police, and even though church is important, our interaction between the two of us is more important. So we're definitely not the church police. We also provide grief and loss support, and that's that can be with family members, that could be with patients who lost other people during the COVID outbreak, or even employees that we talk with. Our unique twist is we're able, as a religious leader, we're able to provide hope and strength. We do that a couple of different ways. And Bernard, I apologize, I didn't put my timer on, so I know we only have a few minutes to talk, and just kind of wave to me. It's always a bad thing to put a Baptist trained minister in front of a captive audience with a microphone. So they teach us on like sentence, we could talk an hour or two on that. So I apologize, and I brought my phone up here and I got sidetracked, and I forgot to put my timer on, so I'm like totally lost. So I apologize for that. Another thing is like faith and trust is a thing that we deal with, especially on the religious aspect. One of the things that's really important, we also actually talk about mortality. That was huge during the COVID pandemics. I couldn't tell you how many people that would come up to me, that would be the family members, that would be on the phone rather, but staff members that would ask me to talk to a person who's came in either severely with COVID symptoms, or maybe moderate or mild, and they've gotten worse. And they just said, Kevin, I think I'm gonna die. I don't think we want to make this. And so we would sit down and talk. They wanted to know, are they going to heaven? Are they actually a good person? What did they do wrong to deserve this, this COVID and stuff? And that was like a constant. We would probably, at least myself personally, would talk to at least 5 to 7 people a day about that. And it was just extremely, extremely challenging for these people. And it's not like we're talking here and there. They're in a lot of pain, and they couldn't breathe for the most part. So that really intensified a lot of their conversations. We also talked about kindness and forgiveness, which was a big area for us. So one of the things I wanted to mention, a psychiatrist from Duke University, Harold Wing, wrote back and did a paper back in 2012. It was on religious studies inside a hospital, and it basically showed that 90% of the people that were hospitalized used religion as a marker to make a healthcare decision. And out of that 90%, 40% of these people religion would be their number one primary factor to make a healthcare decision. And we see that. We see that pre-COVID, we see it after COVID. We certainly saw it, saw it during COVID. So the concerns that brings up is that their beliefs may interact with some of the treatment plans that may be going on. To give an example, Dr. Baraka will see this in the trauma bay, is that we get a person that comes in, they need blood, and we find they're a Jehovah's Witness. So the first thing he does is his head works towards me, and we're now we have to go through this process of figuring out, what we do, but that changes dynamics. It's not right or wrong. It just changes the dynamics. This is like 3 o'clock in the morning. I usually work with him on Friday nights. So it's just one of the things that we have to look at, and we looked at COVID as well. People had decisions that being a Christian, people would come up, the families would call me and they say, well, I'm praying for a miracle. Jesus will give this person, my loved one, a miracle. And I'm a firm believer in miracles by all stretch of the imagination. But we have to be concerned about, what that miracle is going to be. That may not be the miracle that we're looking for, right? It may be the miracle that God sees appropriate. So we may not have that same mindset. So pre-COVID, we had basically 4 emergent resources, and I think Dr. Rooney is going to talk a little bit more about what we're doing now. Pastoral care being the frontline resource. We also have a CISM team in place, critical incident stress management, as well as the employee assistance program would be a counseling, and also we have the Department of Psychiatry. So those are our 4 basic things that we had in place. When Dr. Friel says, when he's talking about communication, his communication, he was given Anthony Fauci to run for his money. You would see him on the news, you see him in the paper, on the radio. He was getting the information out at our morning leadership puzzles over the place. And we actually use, in the way the information trickles down to us, at least me, using his daily updates to kind of pivot our care on what we would expect, what we needed to do and what we needed to ramp up. They helped our department and they really helped the community as well. Dr. Friel, thank you. So those daily updates were phenomenal. We also increased our COVID beds, both ICU COVID beds, the moderate and low level COVID beds. And that just means more staff that we had to work with. So we implemented our stress team. We had 24/7 coverage at our 2 main sites. I got the 2 main COVID numbers, or COVID patients, I should say, which would be the Cedar Crest campus and Muhlenberg. So we activated them, and they were there 24/7 with pastoral care, and we just kept going rounds to rounds and just kind of, listening to staff members, talking on the wave. We were able to go into the rooms and sit with the patients, talking with them, and that was a blessing for us to do that, because I think as a clergy member, it really helped them because they had no family that came in. It trained us on our coverage, but the people we were able to meet with, it worked out well. So I'll kind of cut it short because I think probably cut it long just at that time. So thank you very much. We're definitely here for questions afterwards, and thank you for your time.
Hi, everyone. Thank you for this opportunity and to hear from all of you just sort of what this experience, right, has been the past 2.5, 3 years. When I saw this picture and I thought to myself, if I saw this in 2015, this seems so foreign to me. And yet this is our reality every day. I work in the ICU. I see as much of it as the adult side does, or rule outs, et cetera. And And to me, beyond the emotional toll, this exhaustion is getting at our core. And we weren't the first ones to recognize this. And it's not new in this pandemic, as everyone's highlighting. The nurses actually are always the first ones to know, right? They always know what's happening, have the pulse, feel of the pulse of a unit, of the patient, through the eyes and ears. And so they knew situations of moral. This has been going on for a while, and people expect all of us, right? Be saving lives. We're used to seeing life and death. We're used to always being at the crossroads. And that's where society expects us as nurses, as physicians, as chaplains, social workers, everyone to actually have endless compassion, endless resources of resilience, because that's the expectation of what healthcare does. We heal, see the vulnerable every single day. But what we know is a pandemic completely changed our norm. And so many of you had mentioned banners and the heroes. But when we talk to people who are behind, this identity never resonated at all. And why is that? It's because this pandemic, it brought more fear. It brought more hopelessness, sad feelings in huge waves, as was discussed. And we started to witness the imbalance of suffering. ICUs, ERs, traumas, we're used to at times. But now everybody, you have your outpatient teams, you have your workers, everybody who knows somebody, right, who was either deeply affected with COVID or themselves. So this imbalance was very hard. And then I can't even begin, you all have mentioned, the amount of considerable loss. In the US, it's not expected that we lose people day in, day out. Perhaps a unit can suffer maybe a few deaths in a month. But the fact that now in a shift in a week, you're seeing triple those amounts. Step away, don't have time to debrief, connect with people, and you barely recognize. And we are behind all the protective gear we have to be done. And outside of the loss of life, we all experienced, everyone, children, adults, everybody, loss of our normal routines. And this was such an imbalance. Our usual traditions, can't gather for Thanksgiving. Got to make sure you keep family, young children, older parents safe. And then at the same time, we lost a lot of who we go to for expertise of that. And as leaders, you had to fight now instead of having people in loss of who we normally trust. And we lost, as you're all aware, social connections, which in medicine is so huge, right? We depend, we can't do anything without a team of people. And then starting to lose people who you used to rely on, your experienced nurses who knew how to run a unit with their eyes closed. You now have, charge nurses who barely have a year's worth of experience, who are now taking on these roles and don't have the experience to help support the rest of the teams. Of course, we speak to the change patient-physician relationship, where we used to be able to have a more collegial sense and a supportive role, and now it's perhaps a little bit more antagonistic. And so people mentioned, we all entered medicine for purpose, meaning, or whatever chosen profession you're in, but this pandemic has now caused a lot of people to start questioning it. Is our purpose in all of this? How do I maintain purpose and meaning day in, day out, when it's just exhausting? So I mentioned the nurses knew about this in the 80s. They saw it, they were feeling it. So moral distress is not new. Back in 1984, Andrew Jamison was teaching a classroom of nurses, and they were describing their experiences. And that's when he came up, he's a philosopher, and he came up with this definition that the nurses that he was teaching were experiencing moments where they were having moral and ethical problems, and they recognized it. They felt this deep sense of responsibility to do something, but they couldn't speak up. They couldn't act. They couldn't carry out their true values, and it was affecting their core, their sense of professional integrity. And that could be due to a lot of various internal, external constraints. I'll hit some of them because they still ring true today. Also remind us that moral distress, it's inherent within medicine. For us to think that moral distress should be eliminated, it's the wrong approach. right? It won't ever be eliminated. It's part of the fabric of what medicine, healthcare, and dealing with lives and people are about. Why this is so important, I love this graph that they published back in 2009, is because when you experience moral distress and you never have the opportunity to actually address it, the residual remains. So you can only imagine what a pandemic, if you're doing multiple shifts, people are dying, multiple conflicts, that this crescendo effect keeps building and building and building. You never have the opportunity to return back to baseline. And for some of us, you know what, I can handle 25 of these experiences and I still won't break. But for others, perhaps it will only be the second time. Perhaps it will be 50th time. And you never know where one person is on the spectrum. We do know, and what the literature supports and highlights, if you don't address and speak to this, that this continues to build. So the crescendo, the residue effect continues. And over time, it just gets worse. What are the major root causes? So again, this is not pre-pandemic. They identified back in 2012 major root causes, which they highlight as clinical situations, internal and external constraints. And I'm going to highlight a few that I still think is very relevant to the pandemic today. Prolonging the dying process through aggressive treatment. We've all seen it. We all feel it. When we hear about it. And this is one highlighted as one of the shared common clinical situations for everyone. That is a very trying process. When you're providing false hope to patients and their families, because we're dealing with a lot of uncertainty and we're dealing with a lot of unknowns. We're dealing with new technologies, new medications, a lot of quick changes. And perhaps we don't want to deal and discuss the mortality and the existential, the questions. The perceived powerlessness. I think all of us, right, at some point or another, felt completely powerless in the whole entire situation, over our personal lives, over our professional lives. And when everybody feels powerless, it brings that whole team sense also down. And also the socialization to others. Now, who do I follow? Which values are going to override my decision making, my interactions with others? How I decide, do I get a vaccine? Do I not? What do I say to my colleagues, et cetera? But it also highlights the common things within medicine, right? They're constant inadequate communications among team members. And so as leaders trying to really communicate and re-emphasize and show we're hearing you, but the message may be changing daily because we keep up with the constant information that's coming to us. So a lot of information overload. But at the same time, we're all trained differently and our minds and our perspectives are different and unique. And so nurses and physicians, respiratory therapists, chaplains, social workers, we all may think about how to manage a patient very differently. And those perspectives all come to a clash at the patient's bedside. And whether we're now no longer standing at the bedside, these discussions are either being internalized or being had in conference rooms or via Zoom or Microsoft Teams now. Can't mention the inadequate staffing and turnover. Back in 2012, I don't think that they imagined the degree of today by any means, but we all knew the pressures of we don't have skilled people at the bedside, we don't have number of people at the bedside to meet the rules, to meet the expectations of what we think is the excellence of healthcare delivery. We don't understand the toll that it takes on the teams. But now we are understanding this because we're seeing it and we're living it. And we perhaps don't have all the resources in place to recover. So we're just doing a lot of patchwork. And then hierarchies within healthcare systems, right? I'm going to argue hierarchies at times are necessary, right? We see it in the military, we see it within other structured organizations, we see it when a code is happening and you need someone to just sort of take charge. But then at the same time, how do you balance that hierarchy so everybody has that voice, right? To be able to speak up, to also feel empowered, et cetera. And then the lack of continuity of care. I highlight this as the top because so many people are leaving. It's not just the nurses, it's not just the chaplains, the social workers, your teachers. There's a lack of continuity in many of the fields that actually are so integral to actually supporting everyone and the patient at the bedside. So the literature highlighted that we know when moral distress exists, it leads to wellness crisis, it leads to poor functional teams, it leads to quality and safety issues at the bedside, it leads to burnout, it leads to this ongoing spectrum of moral injury, moral suffering. When you look at these references, this is all pre-pandemic, 2017, 2010, 2004. So all of this used to be theory, and now this is so much more tangible, I think, to all of us at the bedside. And why this is even more important, I think this is the key slide. Instead of just that we're stuck in the emotions and we're looking at the numbers of statistics of our job turnovers, it's really getting to the core of who we are. And it's not just causing existential crisis in our patients and the people we care about, it's actually causing that within us. We're wondering, what is our meaning? What is our purpose within our profession? We talked about all the shifting roles that people constantly have to take on. When you don't have other people to fill roles, you're now doing multiple people's jobs. And they're like, well, who am I? Is this what I envisioned when I left medical school or nursing school or PA school? Is this what I imagined for myself and my career? So at times, what ends up happening is this becomes a sense of personal failure. You have thoughts of leaving the profession. A lot of people just do. And then at the same time, you don't know how to receive necessarily support and help from your colleagues because you feel like you're alone. But at the same time, you also don't want to, make other people start worrying about you or start causing other people to think about these things as well. So we did a survey in May of 2020. So we're reaching sort of this peak up until September of 2020. They surveyed peds critical care physicians and healthcare workers, and also the adult critical care and adult internal medicine teams. Sharing just two quick facts that 86% of our total respondents, so we had over 330 peds critical care healthcare professionals, over 500 adult healthcare professionals, 86% responded to currently experiencing moral distress. And 51% stated that they were experiencing that to a moderate to a great deal. When we asked them about this lingering distress, they experienced the distress before the pandemic, they stated 85% of them stated that they will experience ongoing lingering distress. And 54% stated a moderate to a great deal. So what does it show us? It shows us that we're still hurting. This is exhausting, but it's not new. And it also, I think, gives us a sense of hope because it shows that there's opportunities for all of us to be engaged into helping to foster our own moral well-being and that of others. And I think that this is what we're going to hear from the rest of our colleagues on how organizations and systems are trying to do that and empower one another within their teams. So we really thank you for your time.
Thank you, Tess. So again, I'm Kris Rooney. I am the Chief Wellness Officer for Lehigh Valley Health Network. I also, in my clinical role, am a pediatric hospitalist. If anyone's not familiar, it is basically a pediatrician that solely practices inpatient medical care in the inpatient setting. So I definitely can understand where Tessy's coming from. I think a lot of misconceptions about how the pandemic influenced children are out there. And while perhaps we were blessed and fortunate enough not to see the volume and numbers of children with acute COVID facing ventilators and things like that, I will tell you that they were not scared entirely. There absolutely was the fear of this yet sort of foreign entity called MIS-C, this multi-system inflammatory syndrome. And there were days where I came home in the early phases of the pandemic where I was still taking my scrubs and shoes off in the garage and going into the basement to shower, and just didn't know yet, because we didn't know yet if I was putting my children, who meant more than anything in the entire world to me, at risk based on profession. So talk about existential crises. There were days where I'd look my child in the eye and say, man, I just took care of someone that looked just like you, who was really, really sick. So this did not spare a single corner of healthcare. And I can't stress that enough. So with that said, the optimistic title of my first slide is Clinician Distress is at an all-time high. And I don't think that that's news to anyone. And that's certainly something that, I've been tasked with in the chief wellness officer, to sort of try to pinpoint where our pain points still lie and how we can potentially start to work on improving this. But I think points are well taken that this did not start day one of the COVID pandemic, for sure. So this is sort of a long haul kind of a project that we're going to need to be tackling together. The data that I'm quoting here is actually from the Wellbeing Index, and that happens to be a tool that we utilize at the Health Network. It comes out of the Mayo Clinic. And it talks about the fact that the latest data shows that more than ever, healthcare workers are experiencing burnout and distress. And the impact is significant. We already talked about the turnover rates, staff shortages, increase in likelihood for medical error, which rocks us to our core. Nobody wants to think that they could make, mistakes or, significant mistakes based on what we've experienced personally, but it is real. Costs of nearly $6 billion per year, secondary to clinician distress, whether that be, related to turnover or attrition or otherwise. Extremely tragically, the rate of suicide in clinicians has continued to increase since the start of the pandemic. I will put out there that September is Suicide Awareness Month, and so please do everything you can to share resources with anyone you know, because it is definitely a hidden disease that is out there. And then we also know that further research has shown that 40% of doctors with burnout say they lack resources, and that may mean a number of things. It may mean that they truly do not feel that they have access to resources, but we're also beginning to hear that even if they know certain resources exist, we are the worst at helping ourselves, right? We refuse to acknowledge that we may be in the throes of our own personal mental health challenges or crises. We definitely don't want to let somebody else know that that might be the case. And who has time to go and try to seek help for yourself when you're still trying to, recover from everything that we've talked about happening? So just a couple slides, in case you didn't know. These slides come from Medscape data. Medscape's a national database that does a really nice job of surveying clinicians nationally. So they asked, a series of questions to get at how happy were physicians outside of work before the pandemic, and then they compared that to how happy we are currently. Note they did not say after the pandemic, because we are not really identifying as being there yet. But the sort of green and yellow identified physicians on the left that were somewhat happy and very happy. So that was like almost 81% pre-pandemic. We're still identifying as pretty happy. And then right now, we've unfortunately dropped 35% say somewhat happy and only 24% very happy. And this is outside of work. This isn't, when I'm in there, burning away. This is in general, outside of work, I'm still just not feeling like I've recovered. Which physicians are the most burned out? So this list sort of flips around in order year to year, but certainly within the last year, I don't think it's surprising the specialties that top the list. So emergency medicine, critical care, those are your frontline people that are, really been doing this work frontline for over 2 years now. OBGYN, infectious disease, family medicine. And then the list continues from there. And I think probably at any given network or institution, this list may look a little bit different, but overall, this is the national data. What I think is striking is there's not a single specialty that's falling under or under 30%, with the exception of public health and preventive medicine, which is potentially ironic, but everybody 30% or more feeling this burnout. And then are you more or less burned out now than during the quarantine months of COVID? And the magenta color is women, the aqua color is men. But as you can see, overwhelmingly in both genders, people feel either the same or more burned out now than when we were in quarantine. And there's a lot of postulated theories as to why that may be, but I think it just goes to speak to the fact that we are by no means kind of out of the woods, if you will, in terms of our own personal impacts. So I just wanted to spend a couple minutes just informing you a little bit about the Wellbeing Index tool. Certainly I have no like financial investment in this tool, but it's the one that I'm familiar with. And so I just figured I'd share with you how we utilize it at the network. This is it, actually, in full disclosure, my tracking that I was able to pull. But it gives you an idea of the way that the tool can help people. I have decided to invest in one of those light boxes because clearly I dip every winter and I come back up every summer. And I'm kind of half joking, but I'm half not. You can definitely start to identify trends and patterns in your own well-being if you utilize this tool where you're sort of answering, it's 9 questions, they're pretty simple. But the thing that's maybe even more useful than, you know, your own sort of graph is the index scores that it give you, and it kind of talks about how you're doing relative to meaning in work, likelihood of burnout, fear fatigue, work-life integration, risk for mental error, and risk for suicidal thoughts. And certainly if anyone starts to enter into, you know, sort of the yellow or red zone, there's actually resources that become, you know, available right then and there within the app to that individual on a very private manner. When I get to look at this data, if any area or department has less than 5 respondents, I don't even get to see the data. So it's completely de-identified and completely anonymous when people are utilizing this tool. And then this is the last slide I have, but I just wanted to share, this is a control chart for any of you QI people out there, but it shows the percent high distress rate, which is one of the metrics that the Wellbeing Index tool allows us to follow at the network. And I just find it really intriguing if you look at the blue line, and I'd love to, we should probably do this one time, is line up your multicolored waves with our chart, because I can tell you this is the start of the pandemic. This was probably the peak of quarantine, right? Where people maybe were doing like a little bit better than when they were super, super stressed out. And then it's honestly just climbed since in terms of high distress. In what's that, December of 2021, we and that might be multifactorial. I think that we sort of optimized some resources for each other. I think there was a little bit of a sense of, okay, we might be kind of seeing a light at the end of the tunnel. We're seeing, thankfully, fewer deaths, even if the numbers coming in and out were still there. I will tell you, ironically, July spiked back up pretty decently, but then August came. Here in no way following beautiful predictive recovery curve. This is going to continue to be a curve that has peaks and valleys. And I that this need has existed before the pandemic and will continue to exist long after perhaps we've sort of reached a steady state is going to be, you know, critically important. I don't want to steal our last panelist's thunder with resources, because I think she and I share a little bit of an overlap, if you will, in our roles. But I will tell you just briefly things that I've been, you know, happy to be a part of at our network is of this campaign, if you will, for lack of a better word, where we've tried to really get the message out that it is okay to not be okay. And you have heard that, you know, kind of phrase before, but we really want people to understand and embrace the fact that you've got to be okay with not being okay if you're going to ever get to a point where you're feeling better again. And I work closely with one of our colleagues area. There's a secondary stress response team that's been formed that, you know, comes to the units, comes to the bedside for the providers, for the clinician. So it's not an ability for a whole day to sort of take a minute, but it is the opportunity for someone to acknowledge that we just suffered a lot, you know, in addition to obviously the family and the patient's sufferings. And then lastly, we've built what's called our Wellbeing Council, which is asking individuals from each department, each within our gigantic network, to sort of identify themselves as leaders within their area. work level of wellness committees to start to really have these conversations so that people can begin to feel heard again, because I think that's an important piece of all of this is right now, I think we're all sort of feeling like, okay, nobody really wants to hear what I have to say. And even if I tell people what I'm feeling, I'm not sure it'll matter. And that has a really long lasting chance of, kind of building this loss of hope type of a culture that we definitely want to avoid. So just the fact that people are going to be able to have conversations about what they're feeling, what would really help make a good day at work again, and hopefully begin to make some of those changes. We're kind of excited about that opportunity. So I'll stop there, and obviously questions at the end are welcome. Thank you.
Definitely want to get to questions. I've only got 4 slides after this one. So we'll see how I do at talking. The psychologist is a lot like the other members of some panel here in spiritual care. So I'm Charlotte Collins and I work at Geisinger. Looks like it was going to be. So I just want to kind of summarize things. We had sort of the before and after. I think the pandemic hit the medical field and infectious disease and what are we going to do heavily. It also hit well-being and what are we going to do? And so before the pandemic began, we were currently working on wellness, right? We knew there was burnout, as we've talked about other things, and we had begun to develop a center around professionalism and well-being, and it was all provider focused. So it was physicians and advanced practitioners. That's all the data was about burnout. It was, we had limited programs. We also had a very limited staff, and we just began to do things and develop, and we were gaining buy-in from the system. They were like, yeah, I guess that is a problem. We probably should do something about that. And then the pandemic hit. In a good way, that really opened our eyes to what had been going on and how much worse that could be. And so in a very rapid way, we started expanding programs. And why are we just helping the providers now? It's clearly everyone was suffering, really, from our providers and our nurses on the front line, all the way down to our EVS workers that were cleaning the rooms and the food delivery people. And there really wasn't anyone who wasn't touched by what was going on. Even our financial people, and everything was turned to make the pandemic run and for us to do everything that needed to happen. And so we went from providers are going to be taken care of to everybody needs to be taken care of, which of course expanded the number of people we needed to take care of pretty rapidly. But we got lots more buy-in, and we began to say, what do we need? How do we get there? Let's get moving. So we really focused in what do we need to do right now? And these are the 4 categories. The first, and I think you've heard this across the day and certainly from this panel, is we really needed to listen to what was going on and what people were experiencing, and have people tell us what's going on and what they needed. So listening was really key, and I think that's really important. We also built support programs. We built a peer support program and launched in 3 weeks because we said we all need to have people to reach out to. It was it was interesting, and to Kris's point, 100 people raised their hand and said, I will be a peer supporter. Okay, that's marvelous, right? Not that many people called the peer supporters, right? Because I'm going to help everyone else, but I'm not so sure, like I should reach out for help. People have it worse than me. I'm supposed to be strong. And so there was this very interesting dynamic happening. And then what we heard from continuing to listen was that people said, okay, that's a good idea. Maybe I would call you, but how am I supposed to get off all my PPE and get off the floor and make a phone call and talk to somebody? Like, do you guys know what's happening down here? We can't do that. And so we developed well-being navigators that are out on the floor, checking on people, talking to people, getting known to people. And that's what that taught us, is that we had to have different ways of bringing resources to folks. And then we were doing lots of educational programs. I think we have delivered talks about stress and self-compassion and all kinds of other things to probably 15,000 people over the last couple of years. So people just didn't understand what was happening, some of them. You know, why am I feeling this way? You know, what is this? What do I do about this? And so we were doing lots of programs around where people were struggling. And then we began to really collaborate. I don't know if this happens in all systems, but it certainly happened for us, that everybody wanted to help. And so everybody started something, and we weren't coordinating anything. So we weren't responding in coordinated ways, and we were duplicating services and not having services where we needed them. So we pulled together a wellbeing task force. So at least we knew what everyone was doing, and we pulled our resources and our work together. So those were sort of the early steps in what we did. I am clearly not going to go over all these programs. But what I want to say is that all of our programs came out of an emergent design. That is, what do we hear on the floor? What do people think they need? How do we build that? How do we check back and see if that's doing what's needed? Where did we miss things? How do we keep figuring out what's needed and then make sure that what we're delivering is meeting the need? And that's a lot of work, but you don't make some of the mistakes if you just think it up all yourself and bring it down, because people begin to be involved in that. And so what we have are all these things up here, but there's all different things. Like there's individual things that people can reach out for, and then there's team things that people can reach out for. There's proactive things where we're out there giving resources and talking and trying to find people. And then there's reactive resources when a whole team loses 6 patients that week on the floor. And then there's self-driven things. You can get up on the web, you can read things, you can do things, and guided things that we have other people kind of helping, group things and other things. So making sure that you have this huge variety of approaches so that what matches that person is what they have access to. There's not one size fits all or one thing works for everybody. And the other thing that you'll see up there, and I've heard this kind of alluded to, you'll see things about professionalism, and some people say, why is that in there? And I'll tell you, for us, this is about culture. It's about respect and psychological safety and connectedness. And we have to set that tone if people are actually going to come forward. And if we have to educate them, but if people don't feel safe, they won't speak up even when they need to. And so these are very much linked for us. And we've been working hard on how do we create the culture of well-being, wellness, connectedness, and respect and psychological safety, and all of that, so that together we are stronger. Because we can't get through this kind of thing individual by individual by individual. It takes a team. Medicine works in teams. Culture change works in teams. And getting through tough times is definitely a team sport. So I'm going to end with just the lessons learned. The first is that we simply have to collaborate better. medical systems are often siloed, and we just have to break those down. So you've got to get the stakeholders to the table. There's lots of different ways to do that. We developed a personnel crisis response team. So there's a single line of communication. When we had a crisis in the past, I don't know how, everyone would pick up the phone. I'd get calls, psychiatry would get calls, spiritual care would get calls. You know, all across the system, people would be calling who they knew. Can you help with this? And what we found out was either they didn't know who to call, and so they didn't get any help, or they called everyone and we all came and we weren't coordinated. And so we weren't working together. So we did this. We have a clear text that goes through. We all coordinate. We talk to the leader. We figure out what's needed. We decide who goes and does what. When we started this, they told, leadership said, well, we don't know how often this happens. That's because we never tracked it. We think this is a relatively rare event. And I said, well, I have no idea how rare it is. We need to measure it. See, in 3 months, we had 15 personnel crisis response. That's a little more than they thought. Since they said maybe a few times a year. We weren't tracking. We didn't have a mechanism for knowing. But there have been a lot of these, and our ability to respond efficiently, effectively, and coordinated has been amazing. The other thing I've learned in this pandemic, talk about team sport, is that for me, it's no doubt that we all need to learn how to take better care of ourselves. But the level of intervention that has the biggest impact is team and leaders of teams working together. That's how, when I look at which team did well, they were teams that pulled together. Where did we have the most impact? When we came in with a leader and a team and pulled everybody together at once, that's where they were most effective. And that leads to more effective teams just in general. I think that leaders have been placed in a very uncomfortable position in the pandemic. Leaders and managers who are good leaders and managers had no idea how to deal with high levels of stress, anxiety, depression, moral distress, and burnout. Like, where's the training on that? They were not trained. And so they wanted to help. They didn't have the tools to do that. We did a ton of consults on that with people and managers to help them about how to listen, how to get resources in front of their people. And then finally, the pivot. Our ability to move over here, even if we weren't done over here, iterate, move over here, keep changing it, make it better, get feedback. That has helped us figure out where to put our resources, because resources are limited no matter where you work, and healthcare systems are in financial distress. And so, you know, we have to do more with less. And the way we feel like we're getting the biggest bang for our buck is by really that iterative process and listening carefully to what's needed and have people work together. That's it. Slide 4.
To all our panelists, and we'd like to open it up for questions both online and in person. If you just want to stand up and ask the question, repeat it for the benefit of the folks online. So any questions for any of our panelists?
I'll begin with one from online.
Okay, we got one online.
Dr. Thomas, about your study, you mentioned healthcare professionals were surveyed, but who wasn't included in the study? Were nurses included in the survey that you did? If there were nurses or others, how did the responses differ from physicians?
Yeah, excellent question.
So to repeat the question, so to
Sure.
Dr. Thomas, about the study that she quoted, who were the healthcare professionals included in that study, and were nurses included? And if so, was there any difference in their response?
Thank you for that question. So yeah, we
You might want to
included,
just pick it up.
oh, sure. Can you all hear me? So we included physicians, nurses, respiratory therapists, and APP, so nurse practitioners and physician assistants. And so, yes, a lot of the statistical significance parts actually happened among nurses and the respiratory therapists, where they're the ones who are expressing most distress in comparison to the physician group. They're the ones who are also stating they don't have the resources to actually speak up and actually raise their concerns to leadership. Where when you ask the physician group, no, I have no concerns raising my concerns to our administrators. Physicians, nurses and the respiratory therapist group also significantly p-value significant responses was in regards to their needs, what they needed from the organization. So they spoke about, so I also included questions that had qualitative data come back so people could write their comments about what they would need from their organization to feel better supported. And what people shared was they wish they had open forums, perhaps like this, with their leaders, so they could actually be part of that decision making or share their input from the bedside, instead of having a lot of these new protocols and new mandates come down like top down. And they also shared not being able to find the support of how to vent, because I think sometimes physicians, we feel more comfortable going into a closed office, speaking to our colleague, or we're just going to hold on to this internally because that's just the expectation at times. And nurses and respiratory therapists in particular struggled with that, not feeling included in the decision making for patient care plans.
Any other questions from the audience or online?
I guess for Charlotte, I like the idea of compassion rounds. We had this people stop.
So the question for online about compassion rounds, what are they? How do you do it?
How do you do it? So maybe some of you have heard of shorts rounds. It's a similar scenario. So compassion rounds that we do it monthly. We actually moved to virtual. We always did them in person, and we paused during the pandemic because how could we meet in person? And then people said, hey, we did these, figure it out. That was that listing here. So compassion rounds, they're about an hour long, and they are not an FM, they're not grand rounds. They are bringing people together to talk about the tough emotional things related to healthcare. So what we do is we have one department sponsor the rounds, and they come up with the topic. So I'll give you a couple of topics. Surgery came up with a topic one time that what's it like when you either make a mistake or you have an unexpected complication and you have to go tell the family that? What's that like for you? And then the next day you have to go into surgery and do that same surgery again, and you're not sure you're going to do it right, or you're worried a complication is going to happen, or you're going to make a mistake, and how that impacts them emotionally and how it impacts their practice, their life. Another one was in pediatrics. They talked about, they nominated the topic of what happens when you're working with a family and you're a teenage family, and you're trying to help the teenager and give them some autonomy and follow and their parents, the team, wants a completely different, so a cancer kid or something like that. So, so they talked about how they get kind of stuck in that. And so they nominate a topic that they deal with all the time. They bring a couple of panelists to sort of describe, an experience that they had. Sometimes it's one case from different perspectives, and sometimes it's multiple cases. And then what we've done on the virtual rounds, which has been really, I've rather enjoyed it, is we do that for about 20 minutes. And then we go into breakout rooms. We have a moderator in each room, and we have a group of, 10 people or less who kind of talk about that. We have some guided questions where we talk about what's that like? How do you deal with that? And we're just sharing experiences and dealing with this part of healthcare that causes moral distress that nobody talks about. And so that, and then we come back together and we share from each of the moderators some ideas and themes that came up in there, to all kind of learn from each other and connect over that part. So that. I'll hold
Okay.
this until it's whoever it is.
Yep. Another question, a follow-up question for Dr. Thomas from online is, have you published research?
Yeah, so the slide included those two. Oh, oops,
Yes.
sorry.
It was published.
So yes, it was published. The 2 citations were listed on the slide.
Great. One other question. What have healthcare organizations found to be behavioral characteristics of teams that report the highest levels of well-being? And any report on Gallup's well-being aspects to physical, social, community?
And remember, I've been doing this 6 months, so please take that into account. But interestingly, if you're familiar with Tate Shanafel is out of Stanford and does probably the nation's foremost work in the field of clinician well-being. So a lot of his data would suggest, interestingly, that at least for physicians and APCs, the most direct impact or negative resilience, if you will, with practice does have something to do with their relationship with their direct leader. And I think that speaks a little bit right now to whether that leader has any background or training or sense of how to handle some of the new things we're, struggling with. But it also maybe has to do with that notion of feeling heard, supported. So I think that the data suggests that leaders are inherently bad or otherwise. It really has to do more with, do they feel like their opinions and their needs are valued, and how can that sort of translate into them finding joy in their work each day? So that's one answer. Anybody else has another thought?
Here, I'll add.
So again, that was a very broad question. So if you cover the financial, I'm probably not going to be able to answer that, but I agree with Kris. If you look at what is, Google did a study on this, the number one thing that makes the most effective team, it's psychological. Right there, that leaders who have a higher EQ, leaders who create psychological safety, they set the groundwork for having a team that can discuss things and so forth. We did a lot of surveys at Geisinger around this issue. And what's coming up during the pandemic is, as Kris said, it's, do we feel valued? The couple of things that come up in our surveys all the time with leaders and workers is, do they understand the challenges I'm facing? So are they listening, and do they really understand? So they might say they're listening, but do they understand and trying to do something about it? And the second one is appreciation. Like, we've been doing this so long, and people have, give you pats and so forth, and little, bits, but it feels like the appreciation just doesn't match the amount of effort and stress and strain that people have put in. So those 2 items are something that is relatively easy for leaders to dive into and get better at. 2 things can make a big difference, at least, in the surveys we've done with our people. And if you've got psychological safety and good EQ in your leader, then that opens up the opportunity to really make a difference in those areas.
Right. Here's a question from online. PA student who chose to go into medicine pre-pandemic times and who worked in an emergency department during the height of the pandemic. They struggled knowing that a lot of their medical knowledge was going to be used to treat COVID patients once they finished schooling, not so much because they didn't care about those patients, but more that they were worried that medicine was going to become COVID. Like, it's COVID every day, and it's all you're going to see day in, day out, or a majority of what you're going to see. And then they realized that they were really getting a view from folks who they had looked up to but that might have been burned out. And so sort of, again, influencing that outlook. So the question of all that is going to be, do you think becoming a clinician in the current pandemic climate is less worrisome for burnout? Do you think we're more prepared to prevent burnout as a result? In our healthcare systems, we will work for more prepared to deal with these issues than they were pre-pandemic.
Yeah, it's a fantastic question. And I think the true answer is we just don't know yet. But I think we're going to continue to learn. I call these the pandemic classes. So whether you trained as a nurse, a physician, pastoral care, respiratory therapy, your experience learning during the pandemic was very, very different than your predecessors. And you will always be marked that you're part of that unique generation that really has sought their training. I ask people about this. I do a lot of interviewing for our system. So I ask people about that and what do they think were the highs and the lows. And, certainly, just earlier this week, talked to a critical care person who trained, and they feel better prepared to take care of someone with ARDS and, complex respiratory failure. They know more about prone ventilation. They've more single day than most people who've trained before them ever did in a single year. So there's just certain aspects that they did differently. They've learned a lot about innovation. They've learned a lot about resilience. They've learned a lot about team players, and they've also learned a lot about standing up. But they have seen some of the other stuff, and they all have struggled with, we were a little bit worried that we weren't seeing the same things that our predecessors have seen. And one of the remarkable things, March, April, and May, that we all saw in healthcare, seemed like a lot of other things disappeared. MS wasn't bringing in strokes. We were seeing, the number of acute MIs we saw went down by almost 90%. Now, some of that, I think, people were they were scared to go to the health system. They were dying at home, having bad outcomes that we just weren't seeing. So the experience was very, very different. So I think we have to be very, very sensitive to this. One of the things that I reflect on, I think the pandemic has been a magnifying glass for so many things, professionally, culturally, politically, from a societal value standpoint. It brought out the best in some, and I am so proud of what I saw my colleagues and teammates do at some of the darkest days and some of the worst moments. It occasionally brought out the worst in the others too. And so I think there is a different perspective that these individuals will have. I don't know if we'll ever be able to say it was better or worse. They are a product of the environment and the time in which they trained. I think we have to be sensitive to those facts as we move forward. For some, and this comes up with nursing, they had less patient, bedside time because we move people out, med students, nursing students, et cetera. They had less bedtime. So I think we have to be responsive to that. As we're bringing in new nurses right now, we are more sensitive that they might need some additional training on top of what we've done before. And we're also recognizing that in some of the residents and the fellows that we're bringing in before. But there's a spirit and I think a sense of resilience and other special stuff that's learned as well. So I don't know if it's good, bad. It's certainly going to be different. And I think we have to respect those differences.
Thank you. Yeah, well said. And I guess I would just tack on to, I think, the piece of question that asked, might we be more prepared to deal with burnout or something to that effect? First of all, I want to commend whomever the person asking the question is. I think it's a lot of mature insight to have in a very challenging scenario. So kudos to you. I will say, again, I'm definitely a glass half full person, but I have tried to sort of look and see the bright sides of what has come out of a very tragic time in our lives and in this world that we live in. I will say, I hear people asking the right questions more often now related to physician burnout, clinician well-being, et cetera, than I ever have before. My hope is that doesn't go away as sort of things settle out, if you will. But I do think that we really were sort of forced to look at it more than maybe people wanted to in the past. We have a long way to go with that. But I will say, I think there is something to be said if we're being optimistic that, we're talking about the HMR and someone says, well, how does that impact somebody's well-being? Or how much time are they spending on, their notes, at home? People weren't really even asking or caring, maybe 5-10 years ago. So that's one specific example, but I do think there's hope that this may have sort of brought this into a little bit more of the spotlight, and we can hope for some positive outcomes ahead.
Yeah, just one follow-up. I do, and this isn't so much for the trainees, but I very much agree, Kris, with your statement that this has pushed this to the forefront. And now I'm wearing my leadership hat. We can't neglect this anymore. We've known about it. I think we all recognize it, but it was just kind of one of those nice things. It's important to talk about, but it wasn't priority. And I think now that we've faced, we've seen the great resignation, we've seen the early retirements, we have vacancies in nursing and respiratory care, and we're going to be seeing it in other areas. You're going to see it in physicians, you're going to see it in healthcare administrators, you're going to see it across the board. So I think this has now pushed folks to the point where this has to become a priority, because to differentiate yourself and to compete for a limited resource, you have to create a better environment for folks. It's not just going to be about money. Money's been a big driver of people hopping from place to place, but in the long run, it's be creating an environment that is safe, that is supportive, that is nurturing, and that allows people to find that pride, that joy, and that fulfillment in what they do professionally. So if we haven't learned that yet, we're in trouble. But I do think this is the take-home message that we've all felt as we move forward.
And one more question from the audience here.
Kind of dovetails at the end of what you were just saying, but if you could comment on the change of value-based medicine and how you think it's going to affect physician wellness.
So it's about change towards value-based medicine and physician wellness.
I'll let you know in 4 months.
Yeah. I think we recognize, so I think ultimately this is a good thing. And for where we are right now, we have to start thinking transformatively about how we're giving care. And, perhaps this is one of the other silver linings of the pandemic. We innovated and transformed at a faster pace and at a greater level than we ever had to before. So there's something magical that happens when everyone in a healthcare system is worried about and focused on one singular thing, a pandemic. So the things that we weren't able to do, whether it was telemedicine, whether it was, we figured out overnight how to have one ventilator support 2 people. We never had to do it, but we were planning. Level of innovation and transformative thinking has never been the way it has been. So I think we do need to think differently, because there are things, this is the road to recovery is long. Staffing is going to be an issue, the burnout issue. So we have to start thinking differently about it. How to add value to the system? How do we provide care to the communities where we serve? And the colleagues that work with us doing this, how to increase the value of all those interactions. The system we have to transform, because we're not going to be able to do things the way we were doing. And I think other things we learned from the pandemic, we can't keep doing things the way we were doing because they weren't always working. And in a situation of crisis and stress like we've experienced, it magnified all the things that weren't working a little bit more. So I'm hoping this push to transition and finding value in the way we do things. It's such a broad term, value-based care. It's on some level, it's it's an insurance-based term, but truly looking at value and how we bring that into the system, how we care for individuals, how we care for community, and how we care for each other in the system. That is true value. And those who crack that code are going to be the most successful, and the communities they serve are going to be the healthiest as we move forward.
Yeah, well said. I think the only thing I would add to the how might that impact clinician well-being, it remains to be seen clearly. I think we'll know more a year or 2 down the road, or maybe even, I don't know. But I will say that, at least anecdotally, there are definitely clinicians that I speak with that feel like hopefully this move may take away a little of that sense of cog in the wheel mentality that they've been sort of feeling lately, and maybe bring back a little more of that sense of true purpose and contribution to something larger. And so that would be in my glass half full take on it, but we'll see.
And then one more comment that I'd like to make is that, yes, this should be going on at the network level. This should be going on with current providers. We need to educate future providers, future healthcare workers about this. And we do that with our program, USF. We have a medical school program down in the Lehigh Valley. And we actually educate students on things such as emotional intelligence and professionalism, the ability to be adaptable, to become agents of change rather than passive in change. We teach them about connecting with patients, both communication skills and values-based patient-centered care. And we studied our students compared to the counterparts that did not have that curriculum that were solely down in Tampa. And we noticed that we reduced some of the markers for burnout in our students as opposed to those core counterparts. Will it last? Will we see some longitudinal effect? A little bit too early to tell. We started this program and the first class graduated in 2015. So they're just becoming attendings now. So it's going to be very interesting to see, but we have to be intentional about that education during their developmental phases too, so that they can bring that with them. We also noticed our students were more noticing of disconnects in the healthcare environment with what we're taught as opposed to others. So I think that's something that's important to remember as we are embarking on educating the next generation. We've got to help them now with doing those things so they can bring it into their environments with them. So, and with that,
let's have a round of applause for our panel here today. Thank you. And what a true interdisciplinary conference and how it all came together. I'm sure my colleagues on the planning committee, Dr. Baracco, Dr. Schultz, Dr. Prusak, couldn't be more pleased with the outcome of today. I want to thank everybody for attending, both in the room and online. Be sure to look for your assessment to be emailed to you. That will come as an email and a link to complete that. And then be sure those in the room, you sign out on your way out. Those online, make sure you also indicate your name and your discipline so we can process the CE. If there's any questions or any concerns or issues, we will be updating the conference webpage. You can go there for all the information you need or reach out to us at any time. And again, thank you everybody for coming today and safe travels home.